Hi, good afternoon, everyone. Sorry that's taken me a little long to get everything set up. Please let me know if you can't hear me okay, because I'm trying to use Bob as the simulator to describe a whole bunch of features today. Okay, so for this week's DDU teaching, I was hoping to take you through how to image the critically ill patient with transthoracic echo. It's a really common question in the DDU. Previous examples have included, describe how to analyze left ventricle systolic function in a difficult to image critically ill patient. But I'd like to try and take a bit more of a broader approach because I think other questions would also be along the line of how to try and get decent Doppler angles or analyze aortic stenosis in a difficult to image critically ill patient and things like that. So I'll take you through every tip and trick I possibly can in about 35 minutes. And if anyone else has some great ideas, because I think we've all probably picked up on things from wonderful sonographers during our time, and give me just sing out if you can think of any other good ones, because I think we could all learn, hopefully all learn from each other. All right, so I'm going to try and go through this as I would in a systematic exam for a comprehensive study, and I'll just try and pick up on things that I think about as I'm doing a study, and then little tips and tricks as we go. So as I say, please sing out if you've got any other ideas. Okay, so a standard image, standard echo is going to obviously start with preparing yourself, preparing the patient, preparing your equipment. So simple things obviously is that you've got to start with the patient, obviously try and get them in that left lateral position if you can. So if they're intubated, get someone holding a tube, put a pillow under their right shoulder, tip them towards you. You don't have to be on the left side of the patient. You can be on the right, but obviously our patients in southern Sydney, southwestern Sydney and in western Sydney are a little larger. So trying to image from the right side of the patient can be a little hard. But try and get your patient in the left lateral position. Get yourself in a nice position with your arm level so that you don't have to, so you don't get shoulder injuries. So you give yourself the best possible opportunity and have your echo machine at eye level with yourself, and the machine and buttons easily available, because your right hand for optimization and things is going to be doing more than your left hand. Okay, so that's the basic stuff, getting the room lighting right and all of that. And in an exam question, obviously you start off with that stuff. But let's get into the nitty gritty of the tips and tricks. Okay, so standard parasternal long axis view, we're going to look to try and have the the axis of the heart, trying to get it level with the image plane, and I'm sure you all know that. Okay, I guess the tips and tricks for this view come from me with if you get someone with COPD or on mechanical ventilation or on lots of PEEP, this view is seldom possible in a beautiful manner. So one of the things that we start teaching, you're normally in that sort of second to third intercostal space. You're trying to get a view that sort of looks something like that. And then you just come down the rib spaces as you go, trying to find out where you're meant to be. All right. So as you see, we're meant to sort of be up there in that sort of view in the third intercostal space. Try the fourth. If you can't get anything, try the fifth. And then you start having to angle up. As we go up further and further, you'll notice that the axis of the heart goes and points more and more up. And I guess one of the things that Faraz talked about a little bit, we started a new lecture series called Reporting with the Legends. And I did it with Faraz last week, who's the cardiologist who runs the echo lab, the cardiology echo lab here. And he talks about the importance of the parasternal long axis view from the subcostal view. And I think that's a really nice little place to start from, that if you've got someone who's got difficult to image windows because of whatever, don't forget your ability to get this view here. So you can see I'm in the subcostal position and I'm round with my knob pointing towards the right shoulder. So I'm still in that standard view and I am massively off axis, no doubt. But you can still start to get views of the aortic valve, the mitral valve. If you can fan through that, you can try and make the left ventricle as big as possible. It's obviously not exactly in the axial view, but you can still start to get the angle. You still can start to get a suggestion about how big the left ventricle is. So I guess my first tip and trick is don't forget about subcostal parasternal views. If you can't get it up at the top, just work your way down through the ribs and don't be afraid to go subcostal. Okay? All right, so after that, after you've got your subcostal view for the Dopplers, after you got your parasternal long axis view, we're going to start fanning down towards the right hip, and you get this RV inflow view. Obviously, that's the view where we can start having a look with color Doppler to see if there's a tricuspid regurg jet. I got no obvious tips and tricks about that. We can then tilt upwards so that we can start to build in the pulmonary valve, and we get a nice axis down there from the echo down through the pulmonary valve. I guess the tip and trick talking about hemodynamics in this, if we're talking about trying to figure out whether the patient has significant pulmonary edema, obviously we're looking for tricuspid regurg, but also don't forget with the pulsed wave Doppler at the RV outflow tract, looking for that flying W. And that's one of my favorite things for looking for significant pulmonary hypertension, because it's easy to do. You can't really cause that by inadequate imaging, but you get a nice view down there for your pulmonary valve. Okay. Short axis view. So after we've done our parasternal long axis view, we're going to rotate our probe 90 degrees so that the little marker is pointing towards the left shoulder, and we're going to aim at our short axis of our heart. So that means that we are imaging down. Let's see if I can.
Sorry, Sam. Can I ask before you go to short axis?
Sorry, say that one more time for me, please.
Sorry, before you go to parasternal short axis, can I ask you one quick question on long axis?
Yeah.
So how do you get more part of the aorta to examine if you want to get more of ascending aorta?
Nice. Okay. So maybe I can do another simple tip and trick that you probably all know about, which is obviously the need to get right next door to the sternum. Okay. So in difficult to image patients with COPD or PEEP, we often have, maybe I'm cheating because I took the lungs off. No, wrong one. So I just added the lungs back into the AR image here. And as you can see, if I can try and show it as best I can, that we've got about a 20-cent piece, or if you're listening to the UK, I don't know, a 20 pence piece size in there to try and image. 10 pence piece. I haven't been home in long enough. Trying to get into that little area, often if I slide myself over and I start to see the manubrious sternum, you'll see that that shadow starts coming across. And that's often what people are seeing, and they think that they can't get the ascending aorta. I'll tell people when they're starting to do this, often try and make the whole thing black, which that means that we're literally completely over that manubrious sternum, but then just back it off a little bit till you see the image. And if you want to have a look at that ascending aorta, I make sure that the aorta is in the middle of the image. I'm going to tilt my probe in the direction of the image plane. You see my imaging plane is across there. So I'll tilt that up, and what that's doing is it brings the aortic valve right the way over to the left of my screen, and then I'm just going to try some gentle rotation. And you'll see me just gently rotating the probe, trying to open up that ascending aorta. And then it's just a little bits of fanning, and that's often the best that we can try and get. So it's trying to use that parasternal long axis view to get the best view of that ascending aorta. Bob is being kind to me here, I think we should probably say, and that sometimes it's not quite as straightforward as that. I find that view quite challenging to get, but that's often the best that we've got with transthoracic.
Can you walk us through again what are the movements? So you
Sure.
Go on the sternum, come back. Okay,
so I'll try and just get back to a standard parasternal long axis view. So like a standard parasternal long axis view could be something like that. All right. Right ventricle, aortic valve, left atrium. And I'm getting that because I'm in that little 10 pence or 20 cent piece view of that, just that little area in there between the lung and in between the third and fourth ribs in this case. And if I wanted to have a look at the ascending aorta, I'm just going to try and tuck myself in as close to that sternum as I possibly can, because that's where the ascending aorta is on, it's on that side of the, right behind there almost. I'm going to take that aortic valve. I'm going to try and tip it over so that it's, that ball's in up, tipping it over so that it's on the left side of the image, so that the ascending aorta fills my screen as much as possible. I might try and make the beam width a bit wider. And then I'm going to do some gentle rotation. And what I'm doing with the rotation there is I'm trying to rotate my probe so that I'm then imaging the ascending aorta. So with my other hand, I'm just going to take the back of the probe and I'm gently going to rotate it. But remember, whatever's in the middle of the screen stays in the middle of the screen. So what I then have to do is just fan up a little bit. And it's little bits of rotation and fanning up. Yep. And that's how I get the whole of the ascending aorta filling my screen. Cool?
Sam, can I just ask, is that the same sort of view you're expecting when you do a right parasternal for the aortic arch? Is that what the configuration you're looking for?
Yeah, absolutely. I guess so. So if you're coming in from the other side, I don't do a right parasternal view for anything other than trying to get aortic stenosis, I'll be honest. But absolutely, I guess that if you can get it, that's what it's going to look like. So I'm trying to do two things at once. So if I was in there trying to look up, I can see it from the other side. Yep, so I'm in the right parasternal view, trying to put the lungs back on, trying to get in through the lungs to trying to get that aortic arch view in there. Is that something you use a lot, Kylie?
Well, I guess we're often asked, what's the aortic root like? Because it's a very big problem if you're wanting to lyse STEMIs and things. And so sometimes you can't get it from left. So I've been trying to figure out what right looks like. But thanks for that. I
find it pretty challenging. And I was going to say the other one is obviously to look for it, and Bob's not great at this, I'm afraid. It is going in right from above the sternum, coming down and looking into it. As I say, Bob he's not used to showing these views, but that's obviously as you can do, and you'll get the arch for that one. I think it lacks. It's a bit like trying to rule out PE with a transthoracic. You know, I think you can say that it's there if you see it in the ascending aorta. If you can't see it, you need a toe to try and exclude it. And that's again the clinical situation is going to be a nice. Kylie, it must be hard trying to decide if you're going to lyse someone or not and exclude aortic arch dissection with transthoracic. But that's sort of the best I've got with transthoracic.
Thanks, Sam.
Okay, say again.
Thanks, that's great. That's more than anyone else has showed me.
Okay. Well, that's what this is all about. Cool. All right. So that's parasternal about everything I can say. I don't know that I've got too many tips or tricks for the short axis. Just again, for those starting off with the short axis view, obviously we've got the aorta. As I start fanning down through the heart, you're going to have a look at the base of the heart. As I fan down, you get the base of the heart with the mitral valve. You come down to the mid-papillary level with the anterolateral and posteromedial papillary muscles, and then down to the apex. Just try to keep it a circle, don't let it be an oval. And I guess, or maybe the axis for the Doppler, I guess, is something we can talk about. So when we use Doppler in the short axis view to have a look at the tricuspid valve. So if we're at the aortic valve level, short axis, on the left side of the screen, we have our tricuspid valve coming in, and there's the right ventricle coming around. And often you don't see that pulmonary valve, which is that guy who's going to be sitting just in there. And so the view for that is often just a little bit of anti-clockwise rotation and fan up. Just show that again. So if that's the standard view, trying to look at the base of the heart, so you can see it cutting it tangentially. If you fan up a little bit and a little bit of anti-clockwise rotation, in comes your pulmonary valve and your RVOT. You're not going to have the best angle in the whole world for, for example, trying to do, it's not M mode, I'm just using the cursor, but trying to get down through that RVOT. It's not perfect, but it's sort of the best that we can get. You can tilt the image. Don't be afraid to use that. So you can't do it on Bob, I'm afraid, but on machines, I'm sure you know that you can move the whole image over. And that means that potentially you can just do a little bit of you know, rocking in that direction that pulls the RVOT up into the top right of your image, and that gives you the best angle possible. So when we're looking, you know, when you're analyzing valves, you want to be looking at every single view possible, trying to make that Doppler angle as perpendicular, as in line, as parallel as possible with the flow of blood. So just trying to go, you know, move the image around to make it as accurate as possible. Yeah. So if I was wanting to do it there, that's the kind of view I'd be going for. It's not perfect, but it's the best I can do. And it's better than having, you know, the RVOT there with an angle even more obtuse.
Hey, Sam.
Yeah.
Just with the tilt function, when you apply the tilt, does it apply tilt either way, or you have to adjust it?
Can you say that one more time? Does it add it either way or what?
So when you apply the tilt function,
yeah,
does it go like this way or this way? And how do you adjust that?
The tilt function. So I'll just narrow this down and try and show it. And again, I can't do it on Bob, but I'll try and explain it with my mouse if I can. And so if I've got a view like this, the tilt function will move that entire pizza section of the ultrasound image. It will either move it left or right. So the whole thing just rocks left or it rocks right.
So how do you make it left or right? How do you, because this,
and that's what I don't think I could do that with this guy, but there'll be on the same settings with on a real machine, it'll say tilt there, and you just rock it one way or another, and it moves the phased array of the echo probe either one way or the other. Because this is obviously the echo probe that's sitting in there. It all comes from a single point, but the actual ultrasound beams are coming from everywhere within that section. And so the machine can just phase the timing of it, of the electricity hitting the crystals, to either go a bit more left or a bit more right. And what that does is it just moves the whole ultrasound image looking left or right.
Okay. And the angle, is it?
The angle you can change it whatever you want, but depending on the sector width, you can angle it more. If the smaller the smaller the beam width, the more you're going to be able to angle it.
Okay.
Because it's basically, you know, the echo can take up to maybe an image that look like that, like 90 degrees. Mm-hmm. And if you were to section it down, you could just look at that, and that's the bit that you'd be moving over one way or another. So it's all just changing the phase of the array.
Okay, thanks.
Okay, let's try the apical view. Okay, so as I'm sure I don't need to tell you, you come down to try and find the apex of the heart. You're looking back up towards the right shoulder, and we're at the apical view here. And we all learn about this standard view. So the interventricular septum's down the middle, and you got the right ventricle over here on the left of the picture, left ventricle, left atrium, and right atrium. And that's great for 2D pictures, and we need to have that. If we want to try and get in, the two-chamber view, we put the left ventricle into the middle of the screen, and we rotate around 90 degrees. All right, and I'm sure you all know about that until we lose that right ventricle. Cool. So Doppler, let's talk about Doppler. This is the angle that we're going to be able to get the best views for cardiac output, for LV inflow views, for diastology, for all the rest of it. And so each time you're doing a measurement, you've got to get the Doppler angle perfect. So for example, I'll use this, but it might not work brilliantly. If I want to look at that LV inflow, I'll try and get rid of, I don't know how well that's coming out for everyone, but if I want to get that LV inflow, if someone's got normal LV function, it might look like this. So you've got your standard, beautiful 4-chamber view, and you can see that the blood flow is probably going in that direction. As the ventricle dilates and you get worse and worse systolic function, blood flow doesn't move in that direction, okay? So as you get a more and more dilated ventricle, blood flow, instead of moving in that direction towards the apex, becomes more and more lateral, okay? So as that happens, you know, this is why it's really important to make sure that you're putting a color Doppler on first, and trying to look at the direction of the blood flow. And if they've got a dilated ventricle, have a look to see if the blood flow is going more laterally. And if it is, you need to move the whole probe laterally. So follow that rib space round. Okay, so I was imaging from there, where you can see the interventricular septum's down the middle of the screen. The dilated ventricles, I want to slide the probe laterally to try and, and it can be going in that direction. So it's all about trying to get absolutely in parallel with the direction of blood flow. All right, so that's the first thing. Dilated left ventricles, try and find the path of flow. All right, next thing for the, using the color Doppler again, I'm going to use the color Doppler if I want to go into my apical 5-chamber view. I do that by tilting up, right? There's the aortic valve coming in there. This is where I can do my, sorry, multitasking. This is where I can do my pulse wave Doppler to try and have a look for my LVOT flow. All right, and ideally I want that gate in that LVOT right next door to the aortic valve, looking for that closing click. But I'm going to use my color Doppler to try and tell me which direction the blood flow in, because the blood flow often doesn't come in exactly this angle. I find that the Doppler flow can often come in more at an angle like that. And in which case I want to put my aortic valve onto the left of the screen. I did that by just, if you watch the echo probe, so there's my 4-chamber. I tilt it up to get my 5-chamber, and then I tilt, or I rock my whole probe over so that that aortic valve is sitting there in the left of the image, and that's where I can get the best Doppler angle. All right, sitting in there like that, which is from the true apex down that septum, and that's sort of how the heart works when it twists, according to some of these you know, amazing MRI when they talk about the blood vortices flows. All right, so again, all about trying to get perfect Doppler angles. Okay, next thing with the color Doppler. Let's talk about the tricuspid valve. Okay, the tricuspid regurg. So again, there's our perfect apical, or sort of perfect. There's our apical 4-chamber view, and we often look for tricuspid regurg. Now, tricuspid regurg, I find when you start to get a dilated right ventricle, leading you sort of almost like functional TR, if you like, that often goes straight back. So it's going in line with my cursor movement there. If I try and look with continuous wave Doppler, you can see that the angle is not perfect. All right, because I said the blood flow was going to be in a more sort of obtuse angle there. So what you have to do to try and get that is, again, use your color Doppler to tell you which way the tricuspid regurg jet is going. Because it's very rarely, I think, going over to the lateral wall of the right atrium. It's more than likely always going backwards. And again, so that means I use my color Doppler to help tell me that I've actually got to move my whole probe in a different direction, okay? And our movement is I follow the rib space round the other way. So I slide the whole probe round towards the midline more, and then I can angle down into the right ventricle. And can you see there, now I've got that perfect Doppler angle if it was going straight back. I guess in summary, the tip and trick is you use the color Doppler in your apical 4-chamber view to tell you which way the blood is flowing so that you can get your Doppler angle perfect. After that, it's all about Doppler optimization. So that means that when you've got your Doppler profile, you turn the gain down till you get the brightest part only of the Doppler signal in there. So you're looking at what's known as that modal velocity. You want to ignore the fuzz, or they talk about the beard and the chin. You want to find the chin, you don't want the beard. So that's why you turn the gain down and try and find the modal velocity. So find the chin, not the beard. You put what you're interested in, filling the screen, 3 cardiac cycles, 5 if you're an AF, baseline towards the top. Try and reduce the what do you call it, the filter, the baseline filter, so that you're measuring it accurately. And yeah, and, again, just that Doppler profile, I probably don't need to go through too much, but make sure that's perfect. In terms of the question, so are there any questions so far? Is everyone okay? Cool. In terms of things like LV systolic function, this is obviously where we get ejection fraction coming in. We can talk about subjective assessment. Don't forget about your tissue Doppler if you're trying to assess LV systolic function. Your S prime, it's not perfect, but it's a way that you can do it, and you can often get an S prime reading even with very, very bad images, and trying to give you an idea of with S prime if it's, you know, greater than 5 or something. Cool. What else can I tell you? Okay, let me try and load a pathology, and I'm just going to see if I can find this.
Yes, Sam, can I ask a question? This is Sid from
Please.
Darwin.
Hi, buddy.
Yeah, when we are doing the pulse wave Doppler, say in apical 4 chamber at the pulmonary, at the pulmonary veins, sometimes multiple gates appear. How to get rid of multiple gates?
Very
Is it
nice.
making sense?
Yeah, absolutely. I'm just going to load this up and I'll try and explain that. So on decent echo machines, when you go over what's known as the Nyquist limit with your pulsed wave Doppler, you get multiple gates formed. And, typical, sorry, the pathology I've chosen doesn't show it. So if we had the M mode coming down through here, trying to, imagine that's pulse wave Doppler for me, trying to find your cardiac output. If you're putting it in there, if the depth is like that, you're going to get multiple gates. So the best way you've got to try to sort out getting rid of those gates is to reduce your depth. Okay?
Yep.
Other ways that, yeah, is that good?
Yep.
Other ways that you've got to try to get rid of that is if you change your pulse repetition frequency. Okay? And that's a similar thing's going to happen just by changing your depth. Okay, so the best way you've got getting rid of those depths, or getting rid of the ghosts, as we call them, or the excess gates, is to reduce your depth.
Yep.
It's particularly seen when you're trying to do your pulmonary veins.
Yep.
All right. So, if, for example, if I had this much depth with my pulmonary veins, I'd probably get lots of gates in there.
Yep.
If you reduce your depth as much as you can, think about changing frequency as another option in there. And all of those will get rid of your gates. I generally find with echo, if you just get your depth as short as you can, you should get rid of your ghosts.
And does changing the sector width also help?
Yeah, interesting question. I wonder about, I don't think it does. I think it's because when you're doing your pulsed wave Doppler, try and stop this. Stop your 2D picture. There's often on a GE machine, which is the ones that I use, there's just a button that says 2D on it, or just try and always stop your 2D picture when you're doing your pulse wave Doppler if you can, because that makes your pulse wave Doppler profile that much clearer, because all the machine is then doing is focusing on the gate.
Okay.
Cool. Right.
Two other things you can do. Sorry, Sam.
Hey, buddy.
Hey, it's just Richard. Obviously change the baseline and move that second HPRF sample volume out of an area where there's any blood flow. If it's really deep and you can't get rid of the second HPRF volume, move it right up over the proximal LV apex where there's no blood flow, or over the myocardium.
I didn't know you could actually move those. I thought they were fixed, so you can actually move them, can you?
Yeah, you can move usually you can move the second sample gate. If you're in high pulse repetition frequency, you can usually take that second sample gate and move it. So something that I used to get us to do is put it right over the LV apex where there's no blood flow.
Nice.
Okay,
thanks.
Sounds good.
Okay, this is the next little tip and trick. And again, you mentioned Iris, and I think about her every time I see this pathology. So Iris is the queen of off-axis imaging. And she's amazing. For those of you who don't know her, Iris was used to be the lead sonographer. She was an amazing critical care nurse and then got into echo, working with Prof. McLean, who built the echo lab here and taught me echo. Amazing teacher. And she taught me this. Sorry, again, multitasking is a bit tricky. Okay, so let's say we got someone who you're working up for potential stroke. When you're looking for stroke, we're obviously looking for intracardiac thrombi. If we see someone who has got even if they're not having a clinical reason, but even if you see someone with apical akinesis, as we can see here, right? You can see the base of the heart is not moving well. The apex is, the base of the heart is moving better than the apex, which is completely frozen. That is an akinetic apex. Blood flow in that region is going to be very, very poor. And that means that you're at an increased risk of forming apical thrombus. Now, if you look on this pathology, if I take my standard apical view, I cannot see a clot in there. Let me just check I've got the right bloody pathology. Yeah. So with my standard apical 4-chamber view, I do not see an apical thrombus. Even if I come down a rib space, I might be able to pick it up, but you can miss pathology if you just stick to your standard view. And that's because you've got a complicated 3-dimensional structure, but a 2-dimensional imaging tool. Even if you go to your 2-chamber, again, you can miss the pathology if you just stay in one plane. So it's really important to fan through a structure. So my 2-chamber here, as I fan through, you can get something that comes in there. But again, the rib's in the way. You've got to make sure you can try and get the best of it as you can. And that involves, as Iris always told me, off-axis imaging. And the best one that she taught me was if you're struggling in your apical 4-chamber view, is to do an off-axis short axis. Okay. Now, a standard short axis view could be something like that. Okay. And again, if you come down to the apex, you could miss it if you're just doing something like that. So that would be the standard view if I'm imaging from parasternal view, right? Iris always encouraged me from my apical 4-chamber view, move your whole probe up so that you can't see anything, and then just slide up a rib space. Reduce the depth, and you will get a view of the apex. You hope. Right? She was always a little better at it than I was, I'll be honest. But this is how you get off-axis imaging. You see, I'm nowhere near that parasternal view. Parasternal view is up there. I'm imaging at the apex. And this way you can get like this short axis view and you can image all the way through that left ventricle apex. Okay? So off-axis imaging of the LV apex in anyone who's got apical akinesis. Okay, and the last, that's sort of all I got for that one. Pulmonary veins, we sort of just touched on it briefly there. For the pulmonary veins, I narrow my sector width. I find that pulmonary veins are really good for trying to determine raised left atrial pressure, looking for severe MR, reduce the sector width, make the depth as low as possible, put your pulse wave Doppler gate about 1 centimeter into your pulmonary vein that you can try and pick up with color Doppler, and you want to turn down the scale of the color Doppler. All right, so when you've got your color Doppler in here, there will be a scale that you can put on that, and you want that scale closer to 20 or 30 centimeters a second rather than the 50, 60, 70 centimeters a second. So you're picking up low flows, and you'll be able to see that little red that's coming in there. That's where you put your gate, and you make your gate about 5 to 8 millimeters. And that's how you get most beautiful pulmonary vein analysis. Again, I find sonographers are much better at doing that than I am. It takes quite a lot of practice. Okay, final thing to talk about, and then I'll stop rabbiting on, is about the subcostal view. There are some really nice articles coming out in critical care about this. The subcostal view is, we've got a wonderful sonographer called Jenny who's really good at this. So our standard subcostal view is this, which I'm sure you all obviously know, where we use the liver as our imaging modality. You can maybe increase up the beam width a little bit, and we're trying to have a look at that apical 4-chamber view inside on. But the subcostal view is much, much more versatile than that. We talk about wanting to see the IVC, and I get that by tilting the echo, the right atrium into the middle of the screen. I then try and fan up and down, trying to find where the IVC enters the right atrium, which is around about there, and then I rotate around it. And that means that whatever's in the middle of my screen in one view stays in the middle of my screen in another view, and that's how we get that view of the IVC. But what hadn't really occurred to me when I was learning echo is that if you then fan over to the other side, you're going to get a short axis view of the left ventricle. All right? And you can even get the most incredible angle for looking at your RVOT. And again, thanks to Jenny for teaching me this. So I'll try and, oh, sorry, I don't have a pulse width. So if you can see there, the angle that I've got down there through my RVOT and into my pulmonary vein is absolutely sensational. So that's really another nice place to try and get analysis for pulmonary hypertension. So if someone is difficult to view for pulmonary hypertension, we can use this. We can also, in the subcostal view, get a nice place that we can get axial resolution to try and measure our RV free wall. And if you can, it's not perfect, but you can also get your tricuspid valve in there, a little bit of rotation, and maybe you can get an off-axis view for your tricuspid regurg if it's quite eccentric. But again, you've got that short axis view that you can then fan down all the way through from apex to base from a subcostal view. So in a subcostal view, we talked about in getting the parasternal long axis view, you can talk about getting the apical a four-chamber view for a standard subcostal, but you can also get that short axis as well as some Doppler angles in there. Obviously, maybe the last thing to say, if you've got a difficult to image patient and you're trying all of these techniques and it's still really tricky, just do a toe, which we taught you last week, so that's fine. Great, so that's about it. That's about all I've got to say about all the little tips and tricks I've got for imaging difficult to image patients. So yeah, summarize it, make sure you've got the patient optimized, your position optimized, your machine in a comfortable position, the lights down. In each view, try a standard view, but then go off-piste if you can't get the view you want. So in the parasternal views, come down even to subcostal. In your short axis view, do your best, but get right next door to that to the sternum if you can. If you're looking for the ascending aorta, again, you can use that right sternal view, as Kylie was saying, suprasternal views. Your apical views, go off axis, and if you have to, looking for thrombus, and use your color Doppler to optimize the angle for the Doppler trace that you're after. With all Doppler traces, make sure that you optimize the picture so you've only got about 3 cardiac cycles, or you're interested in filling the screen, baseline towards the top of the image, turn the gain down so you're after that modal velocity. But Doppler angle is essential, okay? And then subcostal, as I've just shown, you can do a lot of imaging from the subcostal view. So don't just stick with your 4-chamber view. You can obviously look at the IVC, but also short axis views and a very nice view sometimes down through the RVOT. That's about it. Any questions or comments or other tips and tricks that anyone knows about?
Can I ask, Sam, is it worth using that angle correct button on the machines, or are they no good?
I'm not a big fan of those. I think I have heard of sonographers who use it as a last resort, but I think that's what it should be left to, as a last resort. It's not something that I use because you can get most, you can get most angles with this, I find. If you're going off-piste, if you're using that color Doppler, using all available angles, things like in the apical 4-chamber view, and you go tilt up to your 5-chamber, looking for aortic stenosis. You can also do that in your 3-chamber. You can also sometimes get views, from that right parasternal edge, things like that. So just trying to use every available angle you possibly can. So I often find you don't need that tilt function. You just got to go off-piste a little bit. And maybe one other thing that I guess I find when people are training is that they're often not pressing hard enough. We're not trying to image the spine, but if you're finding it hard to get your angle, let's do an apical view because that's probably the most commonly one. Right, so if you get your apical 4-chamber view, so let's say we got an apical 4-chamber view. One of the common things that I see is as you got that 4-chamber view, when we tilt up to have a look for the 5-chamber, is often you get shadow that comes in. And that shadow obviously comes in because you've probably got quite a nice view for your 4 chamber. And I'm sorry, I hope that you can see it, when I'm just underneath that rib. But when I tilt up for the 5 chamber, the rib gets in the way. And this is one of the other common maneuvers that I describe, which it's never going to make it into a textbook because I call it snuggling. And when snuggling is you almost use the skin turgor to just pull, I'm pulling the echo probe down into that intercostal space, and I try and snuggle into that intercostal space. And it's almost just like rolling off that upper rib, coming down into that rib space. I'm not pressing in harder, I'm pulling down harder and snuggling into that intercostal space. So it's about knowing where to push. So sometimes even if you can't get decent images, it could just be a simple thing of the 2D image that you got and making sure you're pulling down off that rib space and snuggling into that intercostal space. Yeah, nice. Asking, so I don't know if you heard that. So Hassan was just saying, asking the patients to take a small breath. Breath hold maneuvers can be really useful as well. Take a breath, hold it, be ready for it, image it. Don't forget to tell them they can breathe again.
Sam?
Yeah.
So with the different probes, when you decide to kind of switch between different probes, because some of the machines we do have like sector probes, but they are like I forgot it's S5 and S8, something like that. When you
so you do on some, if you're with a department that's got you know, money to buy lots of different probes, you sometimes have pediatric probes and adult probes. I mean, I always think for echo you need the phased array probe. You know, one of these ones with the
yeah, but even with those phase array probes, there are 2 different probes.
Yeah, pediatric probes. I guess it's all about. It's going to be about the what do you call it? Often the frequency that you've got in there. So I think it's going to depend on the patient. If you've got someone who's a bit more obese, or you're trying to get more depth, you're going to need more depth in there and more penetration, and you're going to need to use lower frequency as opposed to the shorter frequency. I think if you can use a pediatric probe, if you've got thin patients, I think try and do it. I think the images are always just a little bit better, but I don't know. I've kind of just stick with it. We've only got 1 probe on most of our machines, and I think, much as I like to blame the equipment, it's normally me that's the problem. And if I was more patient and I put the patient in a better position, I tried a bit harder, I tried more off-axis imaging, you know, I can get there. You know, we all know this, that when we can't get decent views, we say it's too hard, we order a formal echo, and then you look at the sonographer's pictures and they're amazing, right? You know, it's sometimes not the equipment, much as I want to blame it. So I think taking time, being patient, getting yourself seated down. You know, I do a lot of echoes on my knees because I'm lazy and I'm doing a quick focused study, and that's probably bad practice. You know, if you're doing full studies, taking your time should be what it's about, but sometimes you have to do quicker studies, just try to avoid bad habits.
Thanks.
All right, if there aren't any other questions, maybe we'll stay. Thank you very much and see you guys next week. Okay, thanks guys.
Thanks, Sam.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.